we started off talking about challenges or maybe requirements for implementing any sort of like shape or form of stratified medicine. Important requirements, first of all, that there's a clear clinical need, so there needs to be a demand from healthcare practitioners, that the approach resolves a problem that's actually out there. So it's not test-driven, but it's driven from clinical needs. That there's clear impact on healthcare decision-making, patient outcomes, costs of care, or reducing workload. So there's actually some benefit rather than just a test that has high sensitivity and specificity, for example. Rolling it out later into general practice, we talked about it needs resource and it needs a budget around it. You might have a fancy machine, but if nobody can afford it or if nobody can use it, that's no use. So there was a talk about conglomerations of general practices maybe using that and making a model around that. There was talk about it needs champions to roll it out into practice, but also to make sure that there's transfer of skills from what maybe is expertise in secondary care into primary care. A need for really good information for healthcare practitioners, but also for patients so that they understand what test results mean. We talked a little bit, for example, about if it's genetic testing and the patient thinks, oh, it's all of my genes, I won't bother anymore about stopping smoking or losing weight. So it needs interpretable and clear evidence for information for patients. Patient voice was considered to be really important in terms of driving the importance of stratified medicine, but also in terms of making sure that that then doesn't result in a lot of increase of healthcare utilization, because patient demand might then roll into additional tests and additional healthcare. That may not always be necessary or without harm. We then moved on to talk about scope within primary care compared to secondary care. Opportunities were identified for prescribing within primary care rather than referring on to secondary care. Opportunities to conduct testing in the primary care setting rather than, again, referring to secondary care. And that could have opportunities to upskill maybe healthcare practitioners in primary care that have been de-skilled because everything has been centralized in hospitals. So we got into positive mode there, where we were thinking about broadening the primary care workforce, upskilling them, generating enthusiasm for stratified medicine because it helps to solve problems again rather than just stream triage and send people off to secondary care. There was skepticism as well, mainly about the lack of evidence for the downstream consequences of genetic testing and of stratification. Skepticism about the need for genetic testing, especially where interventions are very cheap, medicines are very cheap. Why should you do all the hoo-ha about testing if you can just prescribe more broadly, if harm isn't that much of a problem? Or skepticism where maybe the proportion of patients that meet the requirements or have the genetic variation is very small. So what's the benefit of doing all that testing if you only help a small proportion of your patients? Skepticism about the information that might be around regarding the balance of benefits and harms, and about how benefits are expressed, whether in relative or in absolute terms, whereas it might look fantastic in relative terms, but on an absolute level it might not mean too much for patients. And again, making sure that any implementation and any testing is not driven by the new test on the market, but by the clinical need. Evidence needed. We talked about what's needed in terms of evidence, replication and validation, so that not every biomarker is put into the literature and then never tested again, making sure evidence is generalizable across populations, not only healthy adults, but older people with multimorbidity as well. And evidence needed regarding causal pathways, so not just how the test works, but also how it has impact on patient outcomes, prognosis, what can be done about it, and does that actually help to improve prognosis? And there was a feeling that there has been a strong focus on genetics, whereas there might be a lot of scope for stratified medicine related to other types of biomarkers, clinical assessments, imaging, all other types of testing available. Finally, I think information overload we talked about, where the main recommendation was that GPs need to be in charge of the information they get, rather than that they are bombarded by information. We talked a little bit about the alerts that pop up around safety when prescribing, which was clearly an example of how information should not be given. But if alerts are popping up based on genetic testing or whatever, they need to be clear in terms of what's the actual risk, what are the options in terms of next steps in decision making or intervention, and so that the GP and patients are able to make informed decisions. We talked a little bit about embedding information from genetic testing and from the bigger biobank project into GP records, but I think that was sort of like far away on the horizon because it needed so much in terms of resolving coding issues, evidence of impact, interpretation of information, how to communicate the information. So I think we got stranded there a little bit.
Thank you very much.
So this was about how or what innovations we might have in primary care that will help in prescribing, particularly around polypharmacy. The group that we had was quite a diverse group, which included patients and patient representatives. It included GPs. We had a pharmacist as well, and also a secondary care physician as well, which was really good. And the discussion, rather than thinking about what innovations have actually developed in primary care, the way the innovations fell out of the discussion was actually thinking about what actually happens in primary care around prescribing. And so one of the first discussion points was around mode of administration, how patients actually receive their medications. And the simple sort of innovation, if you like, about the use of dosset boxes and to enable patients to understand when to take the medications and on what particular days and what particular times was actually quite useful. But there was this frustration that when there are changes to prescriptions made, either because it's come down from an A&E attendant or from secondary care or happens in primary care, how difficult that actually is in terms of practicalities for patients and their carers in terms of firstly enabling that the change is made, the prescriptions delivered and the adjustments made to the patient's mode of administration. We also had a discussion about who else should take responsibility for prescribing primary care. And we had a good example of the use of community pharmacists. And in one of our particular GPs is from a super practice who has 8 clinical pharmacists, 8 or 6? 8 clinical pharmacists in practice who are responsible for ensuring compliance and adherence to medications, to disease monitoring and testing. And this is for long-term conditions that we see in primary care. Now, 8 clinical pharmacists in practice is quite different to having, one practice where economies of scale won't work. But in those practices, there are different people who might be involved, including administration staff. And the interaction between those individuals and also the electronic prescribing system is actually quite a good innovation. So the EPS in primary care, for those who don't know, is a method in which we can deliver prescriptions directly to community pharmacists. And there was feedback that actually that's been a really positive move and a good innovation in primary care. We had discussion about new care models that might influence prescribing, and this was around having a single provider who's responsible for the local delivery of care. And an example of that was Vanguard pilots, which are doing exactly this. And although I don't think there wasn't a discussion really about potential outcomes from these models, but just the fact that it's happening and it may make a difference to primary care. The discussion then went on to talk about actually, what does stratified care actually mean in primary care? And the GPs were challenged by a patient to say that actually, are we actually stratifying, or do we actually need to stratify? And can we actually demonstrate that we are? And I think the GPs responded by saying, yes, we are stratifying our patients, particularly our at-risk patients, who may be on particular types of drugs that need monitoring, or careful dosing. So, for example, the opioids. The stratification could also occur by the use of biomarkers. And again, we were challenged and asked why we weren't actually testing drug levels in practice. And the answer to that really was, I guess, the clinical utility of that. But it may be that as we go on over time, there are going to be new biomarkers that will enable us in terms of drug monitoring and anticipating drug toxicity. But I think most of the GPs felt that we were monitoring and using current markers such as renal function, liver function to ensure patient safety. And then the final part of the discussion was around the degree of evidence we should use in practice to enable stratified care to happen. So do we really need RCTs in practice, or should we be accepting more pragmatic evidence, from pragmatic trials, for example, or the use of in silico data, from databases and so on. So this, I think this all stemmed from the fact that polypharmacy really is the product. Polypharmacy is really the product of using single disease evidence-based guidelines. And is there any evidence out there that actually what we need is to know whether all this together actually does affect outcomes? And I think that was a good way to finish the discussion, really.
Okay, so our group was asked to discuss the use of screening for common genetic disorders such as familial hypercholesterolemia to improve health. So I think the first thing that was said was that the GPs in the room absolutely felt that primary care GPs could not cope with taking this on. There was a kind of, this isn't going to happen, it will be the straw that breaks the camel's back, it just isn't going to happen. Lots of talk about needing to create a prioritization of the care that primary care offers. So many new tests, so many new technologies, so many new, the new big thing coming into primary care. Do we deal with this? How do we deal with this? What do we not do if we're going to take this new thing on? How do we rationalize this and prioritize the work that is done within primary care? I'm going to give you all the cynicisms first, and then we're going to come to the solutions. A feeling that bringing genetic testing for common disorders into primary care won't save any money from the overall NHS budget. Where is that money going to be released? We'll never see it. It's just going to end up costing more. And a feeling that the existing structures within the NHS don't facilitate developing strategies for new things that are coming in. Is that we're not geared up to actually horizon scan, see what the new thing is, whether it's going to actually be worth doing, and if it is, how do we actually do it? And no clear pathway for the adoption of innovations. For not only the adoption, but then for producing the evidence to suggest that they are actually worthwhile and worthwhile doing. And the final barrier was really keeping up to date. So you've got a speciality like genomics. How do GPs in primary care keep up to date with what is a rapidly changing field, and really the push and pull of education? What education do we need to push in? What is the must-knows you cannot practice without, and what is the pull-in? So a patient comes into the practice with such and such a condition. What do I need to know to deal with that patient? So those were the barriers, but an absolute feeling that this isn't going to happen. GPs are not going to be screening for common genetic conditions. However, Solutions. Maybe we need to redefine what primary care is, and maybe there needs to be another person in the team who might be able to take on that element of care, whether that be an allied health professional. So, you know, within the clinical genetics service, the conditions that we're talking about, a doctor wouldn't see them. You know, why would you have your most expensive person seeing something that actually a fully trained up allied health professional would be really well placed to do? So maybe we need to redefine who is in the team. And a suggestion that if we really wanted to do something like this, maybe we need to have a trial at what models we could use to try and actually facilitate this. And thinking really about different pathways, so using familial hypercholesterolemia, maybe the target would be to reduce cardiovascular events in the under 50s, so you might want to look at smoking cessation, weight control, exercise, and maybe testing for FH would be within that overall package, but one piece of a bigger package that was really targeted at a specific outcome. And then we had a discussion about, okay, if there isn't really a structure to bring in new innovations and new services, maybe there needs to be one, and the possibilities of developing a network of primary care practices who might want to join together to allow service evaluation of practice improvements, of sort of service improvements that would need ethical approval, but it would be low risk ethics. It's not like bringing in a new drug or something, which would allow bringing in of new interventions and testing them and assessing them properly to get the evidence that everyone's been talking about today. And maybe that was something that could be considered. We had a lot of talk about the optician model. Lots of people nowadays wouldn't turn to the NHS to get their glasses, and they would go to Boots or Specsavers, and maybe actually getting your genetic testing might be the same kind of model. Maybe it could be outsourced to another reputable provider, but to keep close links with primary care. And then we thought that whatever happens, there'll need to be close links between primary care and specialist help. So when results come through and we're not totally clear about what they mean, there is immediate access to somebody who might be able to provide that additional care. So in FH, that might be to the lipidologist or to the cardiologist, and to find a way of facilitating that. And then other ideas we thought was obviously education and the need to provide it. And also the need to provide some education for the public and patients, accepting that actually the patients might well be driving a lot of this in the future.
Thank all of you. Sorry. Goodness me. Thank you. I'll hold it. But I want to thank all of you for your participation today. I think it's been a great workshop, actually. I've learned a lot, and you know, the interaction has been fantastic. And obviously the speakers in the morning, and chairs and rapporteurs for this afternoon. So what's next? There's no point meeting today while the sun is shining outside and not coming out with anything. So the next step is really that for us to be able to put this together, hopefully in the form of either a report or an article, which is then published somewhere, which hopefully allows a wider dissemination of what we talked about. The second aspect that Martin suggested was that we need to think from this, is there any specific thing that can come out of in terms of a research proposal, which can go to somewhere like NIHR for funding in primary care, to start thinking about particular areas where one can actually start implementing or undertaking a particular research study and so on. And so there may be two different aspects that we will be in touch with many of you in the near future to see how we can drive that forward. So again, thank you very much. Let me just want to again thank the speakers and everybody else. And safe journey home. Thank you.